I will call upon Dr. Mehul Shah. He will be speaking on Eales disease.
Thank you very much, sir, for allowing me to be here in front of you. This is something rarely happening in the urban areas now. It used to be, but now it is not so, but still it persists in rural areas. So, Eales disease with a characteristic clinical picture, fluorescein angiographic finding and natural course is considered the specific clinical entity. So, first described by Dr. Henry Eales, a British scientist, arterial and venule inflammation reported, and etiology may be mycobacterium autoimmunity, which was reported initially. The two major studies published from India is by Biswas et al. And classification was proposed by Saxena et al. Both were very popular and very useful. But other areas in Britain, US, Canada, Greece, Germany are not seeing these cases now, but Indian subcontinent predominantly still looking at the cases, and they reported 1 into 135 to 200 patients, male predominant, that is well known. So these are the etiopathogenesis, tuberculosis and hypersensitivity tuberculoprotein was considered to be the important cause, and other systemic disease like sarcoidosis and association also can be there. There are large number of biochemical study, but Rangarajan et al. And Pratap et al. Studies, they considered the identification point. This is a summary of immunological studies done for Eales disease, and we will not go into details of that. And these are the diagnosis: proliferative vascular retinopathy and systemic and ocular. These are the differential diagnosis. We all know this. So we have conducted a study at our hospital to identify the clinical classification of the. So objective was to investigate the clinical features and propose a new staging system based on clinico-pathological correlation and formulate a new guidelines for management of this disease. It was a prospective cohort study. From 2004 to 2021, all patients were enrolled, and they were classified into inflammatory stage, ischemic stage, and stage of complication. Patients were treated accordingly, and we treated this using medical management, photocoagulation, or pars plana vitrectomy. The patients were monitored according to the standard schedule and formats. These identification points. These were the early vasculitis. Vascular inflammation was seen, either small vessels or bigger vessels. The healed vasculitis also, and sclerotic vessels were seen. And this was the stage of neovascularization. We could see the all peripheral fan-shaped neovascularization hemorrhages. And in later part, fibrosis, contraction and traction retinal detachments were seen. And more complicated retinal detachments also were seen. Fluorescein angiography showed a picture of late AV phase leakage and multiple stunts, and in case of vitreous hemorrhage, USG was seen, and these are the USG done in case of complication and complicated retinal detachments. So proposed staging system was the inflammatory stage, where the treatment was given anti-inflammatory, ischemic stage where anti-VEGF and lasers were given, and stage of complication, surgical management was given. So these were the systemic investigation considered, and medical management was done in terms of periocular and systemic corticosteroid and anti-metabolite in form of methotrexate. Anti-VEGF and photocoagulation, like we did the laser PRPs, and bevacizumab and ranibizumab were injected in cases of more neovascularization. And surgical management for fibrovascular proliferation and vitreous hemorrhages. Vitreoretinal surgery management of complication done. And VR surgery were planned according to if total PVD, only vitrectomy and endolaser. If partial PVD, vitrectomy, endolaser with or without tamponade. And if traction retinal detachment, vitrectomy with endolaser and tamponade. So we are not going into details of these surgeries. So, management of other complication associated cataract surgery, secondary glaucoma or neovascular glaucoma were present. And these are the results. Our cohort comprised of 367 cases, and visual acuity of presenting cohort was less than 360 in almost 60% of eyes. Only 37.9 needed surgical management. We evaluated the visual outcome following medical surgical treatment. Male predominant, mean age was younger age, and poor socio-economical, 1.7% only had a systemic history, and almost 35% were bilateral. 32% were smokers, and mean median follow-up to 86 days. So clinical features in entry segment, in major 90% entry segment no finding, and rest of have finding which were not related to the Eales disease. In posterior segment finding, we had a vitreous haze in all quadrants, vitreous hemorrhage, vasculitis in all 4 quadrants, rubeosis, NVE, NVD, and macular edema and retinal detachments. Management strategies, what we use is systemic steroid in 65% cases, anti-metabolite in 35% cases, lasers, pars plana vitrectomy in 32% cases, and revision pars plana vitrectomy in almost 10%. So, these are the total visual outcome. More than 624 were present in 50% cases, and no light perception in 1% cases. So when we did the comparative study with the medical treatment, we found the significant difference in all modalities except intravitreal triamcinolone, and steroid versus vitrectomy is doing very well, and surgical patient had a better outcome. So we have studied the newer aspect of demographic details and inter-segment findings and posterior segment findings. This study was published in this Journal of Retina Vitreous, Turkish. Thank you.
Thank you, Dr. Mehul. Nowadays, we are finding very, very rarely a classic Eales disease, because now with all the investigations and all the positive etiology is very much present in a retinal vasculitis, case of retinal vasculitis in a young male. That is what the classic Eales disease profile is. So which cases you are taking? Because certain times in 1 or 2 slides you said it can be tuberculosis can be there, or even the helminthic infestations can be there. So how do you separate a Eales disease from these retinal vasculitis which are secondary to tuberculosis? Or,
I think we have a list of investigation where what we do is the Eales workup.
Yeah.
So when we do all investigations and find out if everything is negative, then only we stamp it as a Eales disease.
Exactly. It is a diagnosis of exclusion rather than an inclusion. So you cannot diagnose Eales just like that in a clinical examination. You need to do all the investigations. And
there is a
second characteristic feature of Eales disease, it passes through the stages. That is another this thing. It do not skip the stage. It passes through the stages. Otherwise, the management you suggested is very classic, and we all follow that. Thank you very much.